Hello, overcomers, and welcome to this episode of Connect Over Coffee. I'm Runsi, the founder of Overcome, and today we are joined by a new friend and a new guest, Dr. Nita Lee. So, Dr. Lee specializes in the diagnosis and treatment of women with gynecologic cancers, with her focus on providing comprehensive and compassionate care. Dr. Lee's research interests include cancer survivorship, cancer disparities, and clinical trials focusing on new therapies for ovarian, uterine, and cervical cancers. We have a lot to chat with Dr. Lee today, focusing on the latest advances in ovarian as well as other gynecologic cancers. So grab your favorite beverage. I have mine, and let's connect over coffee with Dr. Lee. And as I always say, if you have any questions as we go along, please type in the comment sections below, and we'll try to get it addressed post the discussion. So with that, a huge welcome to you, Dr. Lee, to this episode of Connect Over Coffee. An honor to have you with us.
Well, thank you so much. It's an honor to be invited. I think you have an incredible platform, and I really appreciate the topics that you cover and how approachable you make those topics to a wide audience. So I was thrilled to be invited.
Thank you, Dr. Lee. So I have several questions, but let's start with your research interests in clinical trials, right? As I was reading, that your research interests include focusing on new therapies for ovarian, uterine, and cervical cancers. Can you tell us about the clinical trials in ovarian and uterine cancers that you're working on right
Yeah.
and most excited about?
I think that, I'll kind of, I'll phrase it a little bit in the sense of that, I am a GYN oncologist, so I definitely believe in the clinical trials that we need and that we need to design to help with all of our gynecologic cancers. My focus has really been on making sure and ensuring that all patients are actually eligible for clinical trials potentially, and really making people in the GYN cancer space, regardless of their age, education status, race, ethnicity, those types of like participation, which I think is one of the biggest barriers to sort of a lot of those different trials. And so although am very familiar with the trial development space in terms of things, I think my role has really become in obviously putting my patients on clinical trials and being sort of at the forefront of knowing which trials we choose to open and how those trials really reflect the patients that we serve, and how do we sort of make sure that patients understand the importance of clinical trials and can really advocate for potential participation of a clinical trial. Because one of the biggest gaps is that there's a lot of fears, like we may have a lot of clinical trials open and I may look at a patient and say, this is perfect, right? It answers a very good question in a very specific, point of a patient's cancer care journey. But if they have so much fear about even trial participation, we haven't done our job, right? So we have some patients who come to us and are seeking trials. And I would say that's a smaller subset, quite honestly, right? We have some patients who travel far to get trials. They travel far across the country. But we have a larger subset of patients that are really fearful about what that means. And I think I really emphasize, how do we improve that sense of knowledge and the importance of how clinical trials fit into a cancer care trajectory, if that makes sense.
Yes, absolutely. Thank you so much.
Yeah. Yeah.
So, we just finished our Ovarian Awareness Month, right? And we talked about a lot about pap smears that do not detect ovarian cancer. It's an important message. However, in a recent article, I saw that HPVs, specifically the HPV-16s, are detected in patients with epithelial ovarian cancers. So the study goes on to say that HPV DNA is detected in 1/3 of the fallopian tube samples of patients with ovarian cancer. So could you share your insights about this and tell us what should our overcomers know about the implications of this study and the broad messaging that we do as advocacy organizations that pap smears do not detect ovarian cancer?
I think this is a really fascinating study. I'm actually very glad you brought this up because I had not seen that yet. But I looked at this study to kind of think about this, and I thought it was really unique because we've often known that the fallopian tube is the site of potential where ovarian cancer or epithelial ovarian cancers can arise. And there's a lot of different theories on the mechanism and hormonal mechanisms and different things. And this was a really unique study that was looking at, well, what if we look at the fallopian tubes that have been the site of these precancerous conditions in the epithelial world, and they actually looked at like a couple of other viruses as well. And we know that HPV is what's called an oncogenic virus. So it's a virus that promotes cancer formation, and it's well known for cervical cancer and things like head and neck cancer and vaginal vulvar cancer. But this was so unique to look at this as like, could this be like an additional environmental issue, right? So the microenvironment of the fallopian tube, could this also be adversely affected by HPV, right? It's not something we've tested before. I think it still doesn't change the fact that like a pap smear alone, a normal pap smear won't catch it. There are people who are looking at other markers that could be caught with the pap smear. So that's some interesting research that's being done. What it told me was that, when we think about these like global infections and we think about this, we think about how, my first mind came to mind was HPV vaccine, right? We know that that's a cancer vaccine that prevents many, many, 9 different cancers. But it started to get me thinking about how, this HPV vaccine may actually have these other ramifications that we don't even know about, right? So I was very intrigued to think about like, will we ever look at ovarian cancer patients and what was their history of vaccination, right? As like, was this something else that was happening? So I thought it was really, it's hypothesis generating. So it wasn't like definitive in terms of, because it was a retrospective study. But I did think it was a really novel way of thinking about like other both preventive options as well as other like just like the biology of it, right? In terms of what
Right.
the cancers are doing. I thought this was very interesting and good to be thinking outside of the box, if that makes sense.
Yes, absolutely. Thank you. Because I was just thinking the same thing that for years we have been, we know some that cervical cancer and ovarian cancer are very different cancers, and HPV,
Right.
it doesn't, pap smears do not detect. But now with all this new research ongoing, to your point, who knows where this will end and
Right.
how these two cancers may or may not be connected.
Right.
We could find some new discoveries. There could be some.
Right, right. It's just very interesting to think about that whole relationship to the vaginal flora, the microbiome in the vagina, the viral issues, and then how does that relate to what we have internal, right? It has to, but we just don't know it yet, right?
Exactly. Thank you. So, also, the next question was, linked to the genes, and now again with the overlap of the breast and the ovarian. So there's a lot of talk about mutations and genes for our overcomers who are positive. So I was recently reading that genes linked to menopause timing are also risk factors for cancer, including changes in the BRCA1 and BRCA2 genes, which result in earlier menopause and also in increased risk of cancer. Again, this is a new and novel thing that I just read. And so can you shed some light into this for us as well?
Yeah, I think it's really interesting that, we've known for a long time the BRCA group of patients who have hereditary cancers. We've also really been interested in their fertility issues because they have a lot to think about, right? They have to think about how young are they going to be when they potentially do a risk reduction surgery. And a lot of them are also thinking about that infertility space because a lot of them are looking at reproductive endocrinologists and infertility to help them sort of like, basically like get embryos that are genetically tested who do not carry the gene. That's a whole other area of investigation, right? But I think what this does, there are linkages to say that BRCA1 in particular does have a potential risk for a younger age of onset of menopause, as well as diminished what's called ovarian reserve. So a lot of times when someone goes in for like a fertility check or someone who wants to do egg preservation, the REIs will start with kind of doing some lab work that tells them like, what's your baseline reserve of your ovaries? Like, how are your ovaries doing? And we know that that all declines with age, especially rapidly rapidly after 35, then really rapidly after 40, right? But this idea that the mutation can also be something that's actually also accelerating the aging of your ovaries is something that we really need to be addressing with our younger previvors, right? So our patients who are sometimes, for those, that's patients of mine whose daughters or nieces or, are thinking about fertility issues. And so we need to be able to recognize that we often recommend birth control pills for the patients because we know those are protective against ovarian cancer. But we probably need to start a more active conversation with them about their fertility desires and, think about that at a younger age, as well as thinking about like, how do we address this issue of premature menopause, right? It actually may be something that can help give a little people some kind of, I don't want to say comfort because this is such a stressful time, but if they know that their menopause may be a little bit, younger in age, some people may feel more comfortable about actually removal of their tubes and ovaries as a risk reduction strategy. I'm not saying that's great, but we have to sort of know that that's what the actual, reality is for patients. And we also need to know that many of those patients would be eligible for hormone replacement therapy after early menopause. And especially if they've not had a personal history of breast cancer. So I think it brings up just another nuance to what we need to do for the younger generation of patients who are dealing with BRCA.
So, for the menopause thing, though, just going back to it for 1 second. So, if the study was saying that the earlier menopause increases the risk of cancer, is it the risk for BRCA cancers, or is it the risk of cancer in general? What
I
do you
think it was sort of, I would probably need to pull that up again, but I think it was sort of implying that like, is the risk related to the BRCA1 mutation status and the menopause happening at the same time? Do those two things coordinate somehow to say,
Yeah.
if you're going through menopause early, would you then demonstrate some kind of like, does that mean that there's like a phenotype or some like that gene or that gene defect is being more active in your ovaries? Like, could that somehow reflect that? It's harder to tell because unfortunately people have to be so young when we're talking about risk reduction that still the vast majority of women who are coming to see us for risk reduction are often like still menopausal, right? So it is a little bit of a skewed, if you don't get your ovaries removed as part of your risk reduction between 35 and 40 for BRCA1 and maybe 35 and 40 and 45 for BRCA2, then you may also be somebody who may be at increased risk because we've missed sort of the ideal window. So it's a
Right.
little bit challenging to know which was the early menopause because so many of that group will have early menopause that's sort of surgically related.
That makes
So
sense.
I think it became a little bit harder for me to tease that out.
Thank you. So,
Yes.
we just had so many of these international conferences ending. So let's talk about the ADCs and the promising results of MARV. I cannot pronounce the whole name.
Yes, yeah.
On the overall survival and its possibilities now with platinum sensitive ovarian cancer. So
Right,
the
right.
three new things happened as far as the MARV is concerned. So can you talk about this exciting development and what should our overcomers know about this
I think
and be hopeful for?
I think this is, I mean, this is a category of drugs that we have not seen before. So these are basically the antibody drug conjugates that target mirvetuximab specifically targets the folate receptor alpha. And it's currently first was studied in the platinum resistant category because we really had so much limited options for people, right? To think about like how to treat those women because many of those patients, their response rates for subsequent therapies would be 5-10%, right? I think the issue is that now that we're thinking about this and how active this was in terms of like the paper that produced and showed such a much higher rate of response to patients compared to what we normally see. So 42% of patients responded, and that was in a very highly resistant population, right? Now we're thinking about how do we move this into the platinum sensitive population, and is this actually a potential like better option earlier in the disease site, right? And so that folate receptor alpha is the biomarker that patients have to get tested. And so I do recommend all patients should really know what their status is for their folate receptor, whether they're platinum sensitive or platinum resistant. A lot of times we didn't check that we didn't even check that marker until somebody didn't have any other options, right? Now we're saying maybe it will be really important because that's actually prevalent, and people with that both all types of ovarian cancer, platinum sensitive or resistant, may have that marker. And if that marker is present, that could be a signal that could be even higher in somebody who's not as resistant to chemotherapy. And so a lot of it is like the discovery of these trials, how quickly we can get them discovered, and how do we sort of shift them earlier in the disease process so we get the best advantage from them, right? So we're really using them sooner.
Yeah.
And that kind of gets back to the clinical trials piece, right? So people really need to see that like clinical trials are not what they used to be 20, 30 years ago, right? This idea of like last resort, or
Yes.
we don't have anything else to give to you, therefore we're going to put you on a trial. Now, clinical trials are really our way of getting patients on really exciting biologically relevant medicines that really like a couple of years from now are going to be FDA approved. And that I think is something that we really want patients to understand and feel, that if your doctor tells you, hey, you're eligible for a clinical trial, it's not because they ran out of things to think about, right? It's really because they've been very thoughtful about what makes sense biologically. And I think mirvetuximab is the perfect example of that.
And thank you for mentioning that. It's important for our overcomers to know that as well, that now the how the clinical trials have evolved
It's
over
such a
time.
different world.
And exactly. So,
Yeah.
on the folate receptor, I know that they have to be positive, somewhat positive. I know that when it initially started, they had to be a very high percentage positive to be able to get the ADCs. But now that percentage is diminished, which is a good thing, which means it is more inclusive of our overcomers. So now, in your practice, overall, and it doesn't have to be specific, but off the top of your head, what percentage of these patients are actually folate receptor alpha positive, that even in your
Um,
subset of patients that you see?
I mean, I would say that, the rates that have been demonstrated are in that like 20 to 40% range. But I'd say that, yeah, I'd say that's probably what I'm seeing too. It's not everyone. And so that just means that we have to be driving forward with thinking about what are these other markers and the other drugs that are going to go, right? So this idea that like it's not going to be, as it may be a panel that we start to come up with, right, that are really important because they're aligned with a drug, right? So the other drug that comes to mind is all of the data that's on sort of the I'm gonna like blank on the name, but on the HER2 and the data that's on the HER2 positive cancers, right? So that's another marker that that can have a targeted ADC agent, but is sort of pan cancer. So now it's not necessarily just breast, right? Now it's like if you have a HER2 positive ovarian cancer, HER2 positive cervical cancer, then that now all of a sudden that treatment has become like an option for us.
Mhm. Okay. So, onto from the ADCs onto the PARP inhibitors. So I was just reading that PARP inhibitors, and I put this on quote, that PARP inhibitors and their combinations are good options, but they're not enough. There is extreme rationale and reason to add immune therapy to PARP inhibitors. So tell us about the recent not so positive readouts on the Athena and the Prima clinical trials, and why is it significant for our overcomers to know about it?
Yeah, I mean, I'll start with the Prima trial, and I think this was the use of sort of using niraparib, a PARP inhibitor, in first-line maintenance to see what was, how patients would do. And so one of the first things that they looked at was something called progression-free survival. So in newly diagnosed ovarian cancer patients who had responded to their first line treatment, then patients basically were put on this maintenance, right? And that initial data was very positive because the survival or the progression-free survival of those patients was actually different, right? But now the newer data came out that was looking at like, well, how did people do overall in patients, the overall population, or very specifically the homologous recombination deficiency population, which is sort of related to to BRCA status and other mutations, right? So there was no difference in overall survival, which I think is, was disappointing, right? People really wanted to see that show up as well. But it is a little bit, there was still benefit in patients who, like, how many patients were living at 5 years, right? So compared to patients in the very specific homologous recombination deficiency population, which includes the BRCA patients, whether they have BRCA in their germline or hereditary, or whether their tumor had a mutation, those patients were still more likely to be progression free and alive at 5 years compared to patients who got the placebo. So there's, I think overall survival is often the gold standard, right? That's what we want. We want to compare that. The tricky part is that many patients who got placebo on the trial, like, there's a high percentage of them that went on to receive the PARP inhibitor later on in their course, right? So there's some confounders to overall survival that kind of show up. And the study was, the authors are very transparent. It didn't meet overall survival, right? We know that. We also know that we sometimes have to take some of the value for where it is, right? In terms of things, progression-free survival, you're right, it's not the only thing that we want, but those, in my opinion, when I think about it from like a quality of life perspective, and when I think of it from like a survivor perspective, those 5 years are really good years, right? They're good years that may be on a drug that maybe is not as toxic, it's oral, so you're not spending as much time in the, in the infusion center and appointments. And so no one wants to take away the fact that we're always shooting for overall survival, right? But I do think that there's value in keeping people disease free or living with disease, but not as affected, so that their like day-to-day life is as minimally affected as possible. Does that make sense? So I'm not trying to tell
No,
the authors that, like, or say something differently, but I think there's value in knowing what we can do.
I think this is very significant what you just mentioned, because yes, overall survival, as you said, is the ultimate objective and the goal, but the progression-free survival, it
Yeah.
is so important to the quality of life. And
Yeah.
just as you mentioned, those 5 years, if you are, if you go to fewer appointments, if you take
Yeah.
more travels, you
Right.
more
Right.
things, and then your quality of life and your meaning of living is so much more enhanced for those 5 years that you are progression free. So very important that we look at that as well. So from the progression free survival perspective, though, how did the final readout of Athena and Prima?
So that was the where we did see sort of like progression free survival for patients, in terms of like both of those studies showed a PARP inhibitor really helped a subset of those patients.
Okay.
And so that's the patients who have the mutation. This is, again, kind of comes back to this like hard thing, right? We have ovarian cancer, but then we have so much like heterogeneity in terms of what does that mean, right? And so that's where this idea that we really want patients and families to also kind of, and everyone has different, health literacy, everyone has different like ability to think about these things. But I think that's something that we want to emphasize to patients, is like really kind of helping your doctor teach you what they know about the specifics of your disease, right? Like, hey, do I have homologous recombination deficiency? Like, how does that affect what you're going to choose for me or my family, right? Or do I have a folate receptor, or do I have these other things? And so that, I think it just really reflects the fact that we really need to kind of like have our patients also know the complexity of what things that we choose, right, or advise about. And so that's where I think there is this value there.
Okay, thank you. So I think you already answered this question that, I was going to ask you about ADCs being a source of hope for treating
Yeah.
patients that are progressing while on PARP inhibitors. Talk to us a little bit about that.
Tell me that again. So you're saying like
So
when they're
basically,
progressing,
yeah,
yeah,
basically I'm asking about, so these are patients who are on PARP at this
yeah,
time, but they're progressing wide
Yes.
and far. Where do ADCs come in, and are they a source of hope for such
I
patients?
think they really are. I think they're just a whole other class of drugs. They do have some different side effects. Like, one of the things that we think about is that the mirvetuximab, for example, we have to have an eye doctor coordinated with all of these, so the side effect profiles are different. But in general, they have a lot less potential bone marrow toxicity. They have a lot less other like nausea, vomiting toxicity. So they're sort of like, there is all of them, nothing's perfect in that sense, right? But at the same time, I think it gives us hope that we can better target those drugs to where the tumor is located. And that's what the beauty of the ADC is, right? So there's this idea that an ADC is always sort of like the targeted drug and the payload that's coming with it, right? So if we can find more ways to be more specific and not necessarily have that same tumor treatment affect all the body cells in the same way. That's kind of the beauty of the ADCs. There's also a lot of data that like the ADCs, by delivering this payload, which is the chemo, right, directly closer to where the tumor is, there is a little bit of a effect that payload will also affect cells that were not folate receptor positive, right, that are in that cluster. So it doesn't. That's why I think you mentioned this idea that like it may, they may widen what the positive, the success rate is in different positive. But I'm not as familiar with that, so I don't want to speak too much. But I think that that's an important area to look at.
Thank you. So I was also reading that while we are on the topic of progression-free and overall survival, that adding the BEV to the combination therapy of carboplatin and paclitaxel significantly improved progression-free survival in patients with epithelial ovarian cancer, but again, not the overall survival.
Right.
Um, so we talked about this a little bit, but in general, I mean, we see this study after study, but uh, what is the significance of this particular study, and what would you say about that?
Well, I think it is comes in this like pattern of like we get a new drug and we try it out in like different phases, right? We first tried it out in patients who have recurrent disease, and we are like, okay, they have a signal there. Let's move it to the front line, right? And then see where that is. And so it probably means that the significance is again the fact that like I would suspect that like if somebody was frontline getting the bevacizumab, which there's some controversy about that as well. There's different practice patterns. Like some people will use bevacizumab in the first line setting, and some people feel like we look at the data and we're like, well, it really only benefited overall survival in patients who had stage 4 disease or suboptimal surgery, and maybe this isn't what we want to put patients on at the beginning, right? So I think it's this idea that like, how do you use these new drugs and tools that come out to have the marathon effect that ovarian cancer survivors need, right? So I always say this is not a sprint. We can't throw everything at you. We have to throw the appropriate things at the right time. And so I think that the sequencing of all of these drugs that are coming out is going to be sort of the key to like more longevity, right? Because this idea of like, when do we use certain drugs? When do we, say, okay, look, you have these very good features. We can actually hold back on this right now. But, it's a really fine line because I think a lot of people want to have everything done, right? But it may not help them, right? So we need to that's where that whole distinction between PFS and OS, or progression-free survival, and overall survival comes in, right? Because there are toxicities related to these treatments, and we have to kind of see which ones are going to help the most at what time, right? Like that's kind of the biggest thing that I think is the issue.
And thank you for mentioning that, because I was going to ask you, and with all these ESMO and other big meetings
Yeah.
we just concluded, if you had to, share the top 3 or 5 findings, and it
Yeah.
that other than the ones that we have already discussed,
Right.
so what would our overcomers?
I think that some of the things were, again, we talked a little bit about this, about the niraparib data. There was some data on looking at like immunotherapy and the use of PARP inhibitors, which I think was helpful, but it actually really didn't necessarily show that there was a trend towards overall survival in this population that was the HRD population, but it didn't, there were a lot of adverse events, right? So I think this idea of like, how are we thinking about, again, like sequencing these drugs are going to be pretty important. The other issue was sort of like some of the data that was presented in the other, gynecological cancers as well. But I think it's, most of it is, I think, the idea that like we have to keep thinking about these like novel therapeutics, right? So this idea that like if there's, there's some studies that are looking at like adding immunotherapy, right, to PARP inhibitor because there's a good signal that this could potentially be important. But we also have to balance like that toxicity and like what are the things that we really see that are happening, right? So I think that those are the kind of some of the areas that I think we need to be always balancing whenever we think about the gynecological cancers in general.
Thank you. So, your recent funded research focuses on endometrial and ovarian cancer survivorship and the importance of healthy lifestyle changes after diagnosis. So tell us more about this particular work that you're doing, because anything related to survivorship is of very significant interest to all of us.
Yeah.
And what were your lessons that could be transferred to our family of patients?
Yeah, I mean, I think this is really important. I think the survivorship work, the funded work was a little bit now getting a little bit older, but it was really on endometrial cancer patients, where many endometrial cancer patients, some of them are really dealing with obesity as another secondary disease, and we know that obesity is a risk factor for both ovarian cancer and uterine cancer. And this was looking at a group of survivors and how could we engage their social network to help them actually improve both their diet quality and potentially weight loss. And how do they feel about this? And so this, I think, is a broader idea that I think is really important in survivorship, is that activation of the social network, right? So this idea of like, how do we, another studies that we have are looking at like peer-to-peer support.
Yeah.
Other studies are looking at like, how do we think about the idea of like resilience in ovarian cancer survivors and the psychological resilience that patients need. So it really relates to this kind of idea of like, if you think about survivorship really needing to be focused on a lot of different domains, health and sort of, physical activity is one of them. Diet and nutrition are really common questions that come up. And then this like social connection is the third, right? That I think about in terms of when we think about like the things that can help patients with their survivorship. And those are sort of all interrelated in some of the research projects, but I think each sort of stands on their own as well, right? If that makes sense.
So, in terms of your, tips to survivorship tips and guidance that you would like to share with our overcomers, what would be
Yeah. I mean, I think I would say that I would think about sort of the different areas that we want to think about your, the survivorship journey and the pitfalls of like people feeling like really good that they're off treatment and then also feeling a little bit lost once they're first off treatment. That's a really common time period where people really need to think about their, people often describe this as like their new normal, or how are they getting reconnected into things. So I think thinking about, again, those domains, like what are you doing for your physical health? What are you doing for your emotional health? What are those kinds of like either activities or things that you can kind of like introduce into your life that you have not done, been able to prioritize before? So I would say that, and finding that connection to where you want your efforts to be is really important. I think advocacy and sort of like speaking about people's own experiences can be a really powerful one, where there's a lot of growth after a diagnosis. And I think that can be very, very helpful for patients and family members. So I would say like just kind of doing like an internal check on like, okay, where am I, right? Where am I thinking about these domains of what we think about? So we think about the physical, we think about the social, the mental, the spiritual, and thinking about this as a time of rechecking, right? To say, okay, where am I in this? And like, what are the things that we want to prioritize? And a lot of those things are interrelated. I think stress is a big one, right? But we know that stress can be improved by both, sort of activities that help with mental health It can also be improved by physical activity. And we're learning so much more about how your diet quality can actually affect your mood, right? So this idea that like I always find this fascinating, which is the whole microbiome side of things, which can be a whole other podcast, but it's this idea that like some of these foods that we eat, and unfortunately it is the processed foods, right, can really affect the microbiome, which can in turn affect sort of all these like neurotransmitters about telling us how we feel, right? It becomes a cycle. So I think thinking about those domains, physical, mental, social, emotional, spiritual, those are the things that I tell people to kind of think about. Where are you going to get your energy from, if that makes sense? So
Yes, absolutely. Thank you. And so, since you are focusing on survivorship, I'll ask you, and I'm pretty sure that you have been asked this question before, because one of the primary symptoms that our overcomers, not symptoms, one of the things that they have to experience and go through and kind of try to manage is this fear of the cancer returning, or even like the scans before a checkup. This is a very common thing. So, and very, very understandable. And I know that there is no like specific answer to this, but from the work that you have done and the patients that you've worked with, what would be your guidance to our overcomers on that?
I would say that kind of accepting that uncertainty is probably the biggest thing that I have learned from my patients and their families, right? And that is very difficult, and it's a skill that patients have had to go through. And that's something that I think as a provider, we have to say, okay, this is my patient leading me through this uncertainty, right? So this idea of what are the tools that you need as an individual person or as a family to accept that uncertainty but still go on with your day-to-day life, right? So some people, it's kind of like, they use different techniques. They're like, okay, I know this is a terrible week for me because I have my CA-125 coming up, I have my scan. How am I going to bolster myself and surround myself with the people that I want in my life, right? So I have patients who are like, I always do a lunch with my sister when I know that I'm about to go to my appointment, or the week that I have, like I fill my time with other things, right? We have some patients who really feel like they need more cognitive help to get themselves from like going down this deep spiral, right? And that's where the use of psychologists and psychiatrists with, sometimes patients really need medication for fear of recurrence because it's debilitating, and that there's no shame in that. And sometimes people need coping skills. So there's cognitive behavioral therapy. There's also mindfulness. These are really powerful tools to kind of train your brain to get you outside of that loop, right? So a lot of people have a loop that we all get down, right? So whenever we have something negative that happens, we often think about like, okay, and now I'm like spiraling downward, and now the whole world is spiraling with me, right? And so I think us kind of thinking about what's your way out of that loop, and really being very, very like it is. I always tell people the same thing. It's a training program. You have to train your brain in that way, right? And some people really become very philosophical. Some people become very religious. Some people use humor.
Yeah.
I had a patient once tell me like, oh, I go around and I say that like, hey, good, hey guys, my family tells me like, hey, I'm going to be alive for another 3 months. And now she is a 10-year survivor, right? And she uses the sense of humor to be like, and dark humor, which is not for everyone, but everyone has their own like coping mechanisms. And I think finding what suits you is probably really important to kind of think of like, we know there's uncertainty, and how do you kind of like accept uncertainty, but sort of like think about it. I think the mindfulness area of like gratitude and focus on one day at a time is something, if nothing else, we've learned from our patients. And I tell our trainees that every day, like learn from each of your patients, right? Like none of our trainees, none of us in the hospital ever go home feeling sorry for ourselves, right? But we also are so mindful of how much we learn about that, like in the moment power that patients have to go through every day. So I think it's really accepting the fact that you're in this uncertain position, but also accepting that you've actually gone through a lot of uncertainty and made it through, right? So people are uncertain about surgery, but they made it through. They're uncertain about this, but they made it through. And so thinking back to those times where you were uncertain, but you made it through are often what we think about.
Thank you for breaking this down for us. And it is so important what you said. The first step is the embracing the
Mhm.
uncertainty, because unless you embrace that, you cannot come up with a strategy to
Right.
go on with the step 2, 3, and 4. So oftentimes, and it's just not with cancer. Oftentimes, we all deal with denial when there is something
Yeah.
that is not quite right in our lives, right? But unless you embrace that, yes, this is a point that where things are going to may perhaps break down, then I think the journey just gets a little more, I don't know, I wouldn't use the word easier, but more, uh, I
Yeah.
mean,
I think it's like more
inclusive.
realistic, right? Like it's like,
Realistic, that's the word.
yeah,
Yes,
yeah,
yes,
yeah,
exactly. More realistic and more, you are probably a little more calm about it as you go through the
yeah,
process.
yeah,
So
no, for sure.
thank you. So we have talked about many things. I just wanted to know Dr. Lee a little more. So what keeps you hopeful and motivated as you do this work every day and every step of the way? And what keeps you motivated about
Yeah. I
ovarian?
mean, I think this is sort of like why we all go into this field is our patients, quite honestly. I think our patients and our families and their networks, I think, are what keep us motivated in general. And I think, for ovarian cancer or all of the GYN cancers, any cancer, quite honestly, like there is this like constant battle between technology, research, and the personal, right? And this idea that like we are really hopeful in the scientific discoveries, and that's where really hope comes from in terms of us thinking about the people who are researching in the lab, the people who are like trying these like, and if you think about it, like research itself is throwing it out there, right? This idea that like we hope that this experiment works, we hope that we get to the next level, right? And I think that that interaction between patients and providers and researchers is a really important space that
Mhm.
I really want patients to kind of understand how powerful their own personal stories or what they share with their providers and their researchers are to kind of keep that um, going, if that makes sense, right? And I think one of the most important things is to just realize like how we have to kind of connect on that human level through those different like boxes that we're all in, right? And that I think is really really important and sort of like the more exciting part. I really enjoy when patients are engaged with asking these research questions and or working with researchers, and equally I really am happy when providers have like a more personal connection to their patients.
Absolutely. And it just makes the journey of overcoming a little
Yeah, yeah.
worthwhile and pleasant. So we have gone through a lot of questions and answers. So what have I missed asking you that you would like to share?
I think you've covered a lot of different things. I mean, I think there's so many different topics that we've covered, and I think this idea of really sharing what's out there with patients is really important so they see the whole spectrum of, the treatment options, that they're not always just and that they're new and rapidly evolving. So I appreciate that, right? Because I think people feel like, oh, you come to the doctor and they should always have all of the answers. But this idea that we have to equally be really um, dedicated to the discovery process, and that each patient who comes to see us, we want you to realize that like we go through that discovery process again and again, if that makes sense, right? Like we are like, okay, let's look up that study again. Let's just look this up. Does this apply? What's the next best thing? So
And I think, what you said is also very important from an advocacy or just empowerment, not even
yeah,
advocacy. From an empowerment standpoint, it is fantastic when our overcomers know what's the next best thing in the
right.
horizon. They know about the advances, or the breakthroughs, so that when they go visit their physicians and providers, they can talk to them about it. And like you said a couple of times during this conversation, that you were not aware of this study, like
Yeah,
because you are already so busy with your own thing. So
right,
not all doctors are catching everything that's ongoing, but
right.
when the patients bring forth those new studies and those new advances that are happening, that it is also very beneficial for the provider to
Very much.
work in partnership with the patient and kind of use his or her expertise to look into those studies, right?
Mhm.
And I missed it, but let me look into those because you
Yes.
brought this to me.
I think that's a perfect example, right? I think I really do appreciate when patients are always saying like, oh, I'm sorry, I looked this up. I'm like, don't be sorry. This is a good conversation, right? Like this
Exactly.
may be something that happens. It's the same for when patients are like, I want to go for a second opinion. I said, I think that's fantastic. We're all in this together to find the best option for you. So yeah, more patients who can like think about that and want to kind of get kind of some, sort of like boot camp on like, what are the things that I should be asking, or what are those questions I think are really areas of programming that I think are really important.
Yeah, thank you. This has been a really good discussion, Dr. Lee. Just in closing, I would love to ask you, because this is a favorite question I ask all our
Yeah.
episode guests, is that what message of overcoming would you like to share with our overcomers that are listening today?
Um, okay, this is a tough one. I should have known this because it was on there, but I would just say that I think that, for our patients who are diagnosed with ovarian cancer and the family members who take care of them, I think that they and you and are just a really incredible source of inspiration for us on our day to day. And I think that that's really important. I think patients do not see how much those moments of connection are really what feed us as physicians and clinicians and keep us from burning out and keep us able to keep going, if that makes sense, and I think that that's something that's a little underestimated in some ways, but I do think those personal connections and like what people bring to the appointments and the personal relationships that we build are really what keeps people going. And it's not to say inspiring in sort of a cheesy way, but it really is. It affects how we view the world, and we really take people's stories and experiences to heart. And I think this affects the kind of people we are, it affects the kind of parents we are, it affects the kind of physicians we are. And that is a really powerful legacy that many of our patients leave behind, whether they are my 15-year survivors or they're patients who unfortunately passed from their disease. I can picture who's influenced me. And that I think is something that people who are part of the overcomer groups should really know about.
That's a beautiful thing you said, leaving the legacy as a patient and an overcomer that inspire you every day. So that was absolutely beautiful. Thank you so much, Dr. Lee.
Yeah.
This was a fantastic conversation. I know that we covered a lot of topics, and we talked about many new things and some new advances, and also your reflections on survivorship and overcoming for our overcomers was very well taken. So thank you. And overcomers, hope this was a beneficial discussion for you. As I always say, please share this information far and wide with anyone who may benefit from all the pearls or the teals of wisdom Dr. Lee shared with us today. And we will be back with the next episode of Connect Over Coffee very soon. Until then, you keep inspiring and overcoming. Thank you and bye.